my pleasure this morning to welcome Professor Klaus-Peter Guenther. He's actually very important also in orthopedic surgery, but he also has a very important role in education. And that's why I'm very happy that he took the chance also to meet the Astro group here. And he's the chair of the educational committee. He stepped down yesterday and takes other functions, but the last two or 3 years we were working together in developing education for young orthopedic surgeons all over Europe. And I'm very happy that he has the chance and provides us today this talk on risk factors and patient selections, joint replacement. Dear Klaus, Peter, thank you very much for coming. I know your schedule is very busy here at the effort, but thank you for coming and giving the talk.
Thank you very much, Stefan. Dear colleagues, it's a real honor for me to be invited for this group because I think this is a major initiative which is very interesting and very promising, and I'm really glad to have the opportunity to give you a talk on a topic which is somewhat specific. I'm not really sure about your knowledge background, and I just would like to ask how many of you are still residents in training? All of you are residents in training, and let's say just in the last year, who's in the last year, who is in the middle, so most of you in the last year. I would like to really ask you to stop me and interrupt and say, what is this, if you have problems to understand something? Because I don't want to present something which is not of value for you, and I would also try to stop a little bit in between for some discussion and try to keep a little bit in time. We have 45 minutes for a topic which is, from my point of view, extremely relevant, extremely actual, the question of risk factors and time and patient selection. I'm working in a German Department of Orthopedics and Traumatology in Dresden, which is in the southeast. I have some research projects with industry companies, but do not get any money for personal consultation. I want to take this point, risk factors, exclusively in the field of hip replacement. We can talk about great toe and neck and spine and everything, but I really want to take hip replacement because, as you know, this is a very successful operation, and hip replacement is a very prevalent procedure, and therefore I want to take the example hip replacement and talk with you about patient selection and risk reduction. What are the most prevalent complications after total joint replacement? You all know dislocation is a problem, loosening and osteolysis, infection, fracture, and other problems. These are several big arthroplasty registers, and you see the frequency of revision procedures, which ranges here for this location between 10 and 20% of the cases. Loosening and lysis, most often. Infection is a problem in all registers, fracture, and I want to go with you through not all complications, but especially through the early revisions. What are risk factors for early complications? Early means in the first months and weeks after an operation, and there we have dislocation. Who of you had never had a total hip dislocated when he operated it? I assume all of you have operated total hips. So every one of us is experiencing dislocation, and I think it's it's the most frustrating when you're coming to the grand rounds in the morning and the radiograph pops up from the night where a colleague has reduced a hip which you operated 3 days before. This is, for me, one of the most frustrating experiences, and I think we all share the same experience. Infection is a major topic of early revision, periprosthetic fracture, and of course not revisions, but non-surgical complications are the cardiovascular events and the non-response, which means a patient who is not satisfied with his result. Everything is going well, no dislocation, no infection, beautiful x-ray, but he complains of pain and problems and is not satisfied. This is a major problem, and you will see, although it's in hip surgery not as often as in knee surgery, it's really a problem, and I will talk about risk factors for that as well. So we go through risk factors in dislocation, infection, fracture, cardiovascular, and non-response. What are risk factors when we are talking about patient-related risk factors? Because, for example, when we take as a first step dislocation, what are risk factors for a dislocation of a hip? What are risk factors?
Dysplasic acetabulum first. Dysplasic acetabulum.
Dysplasic acetabulum. If the acetabulum is dysplastic and you put a very steep cup, then it might dislocate. What are other risk factors for dislocation?
Insufficient posterior external rotators.
External rotators, or especially when you don't do through surgery a capsular closure, when you leave the capsule open, you have a dislocation rate of 4%. When you do the capsular closure in the posterior approach, you have only 2% of dislocation rate. These are both surgeon-related risk factors. When we do not do appropriate surgery, when we change the wrong implant. But what are patient-related risk factors? What is a risk factor on the patient side for dislocation? Who is a patient you would be afraid of dislocation?
Arthroplasty after neck fracture.
Arthroplasty after neck fracture?
A person with Parkinson or, I don't know, Parkinson.
Parkinson disease, neuromuscular disease, loss of control. The examples are patient age over 80 years. Females are more on risk than male patients. Soft tissue damage due to previous surgery and insufficiency. And here you see the neuromuscular disorders, what you said, developmental dysplasia, what you said, femoral neck fractures, what you said. So these are the patient-related risk factors. And one very important risk factor is obesity. The fact ladies have more problems than the very small, tiny ones. And this meta-analysis here clearly shows that a body mass index over 30 is a risk factor for dislocation for several reasons. One reason is a very strong and wide thigh fat, which is just giving a mechanical problem, but other reasons as well. Next topic, periprosthetic infection. What are the main risk factors for early periprosthetic infection? You get around 2% infection rates in large areas. What, from your point of view, are risk factors for periprosthetic infection?
Obesity.
Obesity? Diabetes?
Previous infection.
Existing
Previous infection, of course.
Existing urinary infection or other.
Co-infections at the moment, urinary tract infections, other infections maybe.
Immune deficiency.
Immune deficiency. A lot of important things, and you can extend the list by malnutrition. Not only obesity is a risk factor, but also underweight is a risk factor. Anemia, we talked about diabetes, liver disease, alcohol, nicotine and drug abuse, a lot of factors. And the basic question is not what are the risk factors, the basic question is what can I do to modify these risk factors before surgery. And this is which risk factors are modifiable, and this is a beautiful investigation. I want to talk with you for a moment. This is from 2015, and in this cohort of about 3,000 total hip replacements and 400 revision total hip replacements, they looked at 47 deep infections, which is about 1.3%, and they looked about the association between risk factors and infection. And you see here are the relevant risk factors. The first is when surgery was performed not at the day where the patient was admitted to the hospital, but the patient has already spent several days in the hospital. What is the reason why this is a risk factor? Nosocomial infection. Diabetes, we don't have to talk about that. Revision surgery, we just mentioned it. ASA score, hemiarthroplasty, probably due to the femoral neck and old patient cohort, body mass index over 40, operating time more than 150 minutes, we all know that. One major fact and an increasing factor is the contamination with Staphylococcus aureus, a small caseload, a hospital where only a low number of cases are performed, and a high body mass index. Now the interesting thing is, because we all know that, this group now combined the risk factors and said they took a multivariate analysis and said when several risk factors are coming together, then you increasingly raise the risk, and I personally find this very, very interesting. When you have a body mass index of more than 40 and you're an active smoker, the risk to get an infection is 7-fold higher than a non-smoker in a normal way. This is dramatic. And when we go down, the colonization with Staphylococcus aureus, every one of us is on risk to have a Staph aureus colonization, plus a body mass index of more than 30, which is not a lot, plus smoking, increases the risk of an infection by 12-fold. So a relatively obese lady who has colonization of Staph aureus and is smoking has a 12-fold higher risk of infection than a normal average patient. I think this is very nice and relevant information, and the authors of this paper concluded an infection plan should include preoperative topical antiseptics. Who of you is using in his patients preoperative topical antiseptics? 1, 2.
Just before operation.
Please look in the literature and think about it. There are different substances available where you put the patient on a shower the morning before the operation, you put him some spray into the nose, and you decolonize Staph aureus. It seems to be, I come in a minute to that, possible to reduce the risk of infection. Weight loss and nutrition counseling. Who of you believes that weight loss is an effective prevention? Voila, I'll come back to that later. Poor diabetes control should be managed optimal perioperative glucose management. I'll come back to that in a moment. And the tobacco cessation program. Who of you advises smokers that they should stop smoking before operation? Perfect. Do they do it?
Don't
No?
care.
But you have the
They don't
possibility, I tried it several times and it seems successful to give a kind of plasters, the smoking cessation plasters, which seem to be very effective. The question is, what is the evidence on this preoperative decolonization? A lot of people do it, we do it routinely, and we feel that it's better, but we have no evidence at the moment. Weight loss we talk, diabetes we talk, and the tobacco program, we have all the same experience. It's somewhat, we should do it, but it's not really effective probably. The next topic is perioperative fracture, periprosthetic fracture, which is something which is very interesting. I run just briefly over it. You see from data from the New Zealand Joint Registry that with increasing age, the uncemented prosthesis, which is the gray one, and the cemented are the black one, with increasing age, the uncemented prosthesis seem to have higher fracture rates than the cemented prosthesis. So this is one of the reasons why, obviously, in elder patients, cemented prosthesis has a lower rate of perioperative fracture. But on the other side, when you are doing a cemented prosthesis in old patients, you have, of course, other risks, for example, the thromboembolic event rate and the perioperative mortality. This is just one of our own examples. A patient relatively old with a cementless cementless prosthesis, and on a fall on the 7th postoperative day and a periprosthetic fracture. That's, of course, not the result of the fall. It's the result of a microfracture of a fissure which has been already present here, and when the patient then is going more and more on the weight bearing, he is falling down because the femur is fracturing. You see here that most data from a meta-analysis here is favoring the cemented prosthesis in elder people regarding the risk of perioperative fracture. This is another patient. I did the operation about 8 or 9 years ago. This is the preoperative picture, high dysplasia, high degree of dysplasia, a beautiful implant, the cone prosthesis, and you see the patient was leaving the surgery with this problem here, and I did not recognize it. I was just looking here, everything is fine, prosthesis is fine, little bit of leg lengthening, everything is okay, and I did not look here. And this is 5 days after surgery when she was mobilized. She had a fracture and I had to revise it. So just an example that periprosthetic fractures, especially in the early postoperative period, are more relevant in those patients with uncemented implants. Now, a very interesting thing, cardiovascular adverse events. The cardiovascular problems are related to about 40 to 70% 70% of the major systemic adverse events after surgery, after total hip replacement, and this is really a problem. We don't often consider as a problem. There have been several initiatives in the last year started to talk about risk factors for cardiovascular problems, and several groups have provided algorithms and treatment recommendations. And I show you a nice slide from Lancet where people say, well, obviously we are getting better because the mortality rate over the last years, this is 2003, has decreased and is now in 2011, this was the latest year of this analysis, about half of the mortality rate in 2003. This is a beautiful development. Less people who are dying after total hip replacement, and the authors say, well, this is a proof of our effective thromboembolic prevention program, of good risk stratification and everything. Some people doubt that, and some people say, well, it can be, especially in the United Kingdom. Is someone of you from the United Kingdom? Not? There also can be other factors responsible. In the UK, there is, as you may know, a total joint registry which makes public the complications of surgeons. So every surgeon who is operating in the UK sees his own results next year on the internet. How many patients have problems, how many patients have been died. And this probably also leads to a kind of patient selection. So the surgeons tend to say to patients who are really under risk, oh, I better not operate you and I better refer you to conservative treatment or whatever. So some people argue and say this improvement of mortality rate is not a factor of better perioperative treatment, it might also be a factor of preoperative patient selection. Just to raise your awareness that several factors are playing a role here. Finally, the patient who is not satisfied after surgery. What are, from your point of view, factors which might contribute to a situation where the patient is not satisfied after surgery? Let's have a not complicated surgery, everything is going fine, regular osteoarthritis, no severe problems, and you see the patient 1 year after surgery and he is not satisfied. What, from your feeling, are patients who are not really satisfied?
Or excessive expectation before surgery.
Excessive expectation, unrealistic expectation. What might else be a problem? What are the patients you see in your office and you say, oh, I better not operate on this
Work
patient?
compensation patients. Work compensation.
Work compensation. You mean patients who are not at work, who are getting retirement or a disability pension. So not workers, disability pension.
Inability to do sports.
Inability to do sports, not sportive patients, maybe.
Depression.
Depression. Other factors?
Visual problems.
Visual problems. I just run through 2 or 3 things which explain what we just said. Meanwhile, we know that this non-response, by the way, do you know how many patients after total hip replacement are not satisfied? How many percent? After total hip replacement and after total knee replacement?
5%.
Knee is 20, 70, hip 5.
5%.
Older data says exactly that. Knee 20%, 25%, depends on age and other factors, and hip about 5 to 10%, but newer data seems that it goes a little bit together. The very recent data shows that the gap between hip and knee is not anymore so large, but the data from 2003, 2005, 2008 showed that there's really a discrepancy, and in total knee replacement the people are a little bit less satisfied. But let's go back to total hip. We know meanwhile that there are several risk factors. The very old patient, the female patient, the patients who are socially deprived, who are living in very poor regions, are not very well educated seem to be under higher risk. Low preoperative clinical function, the patient you said who is non-sportive. High preoperative expectation, that was your point. Comorbidity patients with diabetes, morbid obesity, again here is a risk factor, maybe, I show you some data. And psychological factors, you mentioned depression. I just go through a few examples. This is an investigation which very nicely puts together the association of preoperative function and postoperative satisfaction and results. This is from a British group, and you see this is the SF36. Who knows the SF36? Who does not know it? It's a questionnaire with 36 questions, therefore SF36, regarding health-related quality of life. What's your ability to perform several activities? How are you feeling? And so on. And the Oxford Hip Score. Who knows not the Oxford Hip Score? Everyone knows it? Not? The Oxford Hip Score is just a score which is very often used, and you should hear it and you should know it, with 12 questions. I think 12 questions, I'm not sure. 12 or 15 questions. Who knows it? 12 questions. Walking stairs, bending knees, sitting down, going up, and other things. Overall satisfaction with function and daily activities. These two scores, this is health-related quality of life, and this is patient-related function. And by the way, these two scores, the health-related quality of life and the Oxford Hip Score, belong to a class of scores which is today called the patient-related outcomes, PROMs or PROs. You should remember this word, the P-R-O-M, PROM, patient-related outcome measures, because it means you only ask the patient. It's not relevant what the physician says, it's not relevant what the range of motion is, it's just the question, are you satisfied and what is your function? And this is therefore patient-related PROM or PROs. And you see, when you start the Oxford Hip Score here, this is the worst Oxford Hip Score you can have preoperatively. You improve 1 year postoperatively, 2, 3, 4, 5 years, you improve the score significantly, but you cannot improve it as high as you improve it in a patient who starts very good. But the patient who starts very good has not the same amount of improvement. You see that? So in other words, when you operate on a patient with a very bad preoperative function, you can improve him significantly, but you do not bring this patient up into normal range. This would be about normal here. When you operate a patient very early, who is very active, sportive, and has only small problems, you can also improve him, not to the absolute top here, of course. You can improve him, but the range of improvement is not very high. Some people also call this phenomenon a ceiling effect. Ceiling means here is the ceiling. The more you are close to the optimum, the less improvement is, of course, achievable, because you cannot be better than the optimum. This is a ceiling effect. And the basic message here is, you should not operate a patient in a very bad situation and should not wait until he is in an absolute catastrophe, because then you can improve him, but you improve him not to a really satisfactory situation. And you have the exactly same here with the quality of life. When you start with a bad quality of life, you can improve the quality, but not as much as in a situation where you start with a better quality of life. So preoperative function, the basic message is, don't operate the patient too late. But also do not operate him too early, because when you operate too early, the improvement is not very high. The next is, we talked about expectations. You must not read this list, but when you are talking about preoperative expectations, there's a group from New York, Carol Mancuso, who did a lot of work about preoperative expectation. And she was counting just different domains of expectation, and she said, these are 18 different expectations, from relieving day pain up to improving ability to participate in recreation activities. And she found out, and this is consistently repeated in 10 out of 18 items, the expectations are really fulfilled very high. The patients are satisfied. But on the other hand, you have in about 1/3 unfulfilled expectations. And this is, when you ask your patients, you will make exactly the same experience. They are often not able to cut their toenails after the operation. And especially for women, this is something which is not very satisfying. Often they are not able to exercise and play sports as they want, and they are often not able to perform all daily activities at home. We in our department have made an investigation on 100 patients, asked for the preoperative expectation, which is here in gray, and we looked at the postoperative satisfaction in the exactly 18 domains, and you see the preoperative expectation of patients is very high. Nearly all patients say, I want to relieve my day pain, I want to improve my walking, I want to stand up better, I want to be without drugs, I want to improve my sexuality, is an issue in 50% of patients, especially the female patients. When you talk confidently to female patients, they often suffer from pain during sexual activities, and about 50% of them want to improve their sexual activity with a total hip replacement. And interesting is, when you now ask for the postoperative satisfaction at 1 year postoperative, you see many of them are nearly what they expected. The postoperative fulfillment is nearly what they expected. In ability to perform professional activities and sexual activities, the patients are postoperatively even more satisfied than they expected. But on the other hand, cutting toenails and putting the shoes on, the patients are disappointed. So the information you can take with you is, especially the activities to cut toenails and dress the shoes is often not satisfying for patients after total hip replacement, although they can walk very nicely. Next point, how is obesity related with satisfaction? We saw that obesity is related with dislocation rate, with infection rate, with other problems. And you might expect that obesity is also related with not being satisfied, but this is obviously not true. Several big cohorts, including one we have performed in Europe, show that the preoperative obesity on the Oxford hip score and the postoperative satisfaction here is in different cohorts very similar. These are the patients who are normal weight, and these are the patients who have a body mass index more than 40. You see the same tendency as before. The really obese patients start with a lower Oxford hip score and they end up with a not as high Oxford hip score, but the difference is not very high. In other words, if you are really obese, you get the same satisfaction as the non-obese, the same amount of improvement, and a little bit lower satisfaction, but the difference here between 36 and 40 points is not clinically relevant. So the obese patients have a higher complication rate, but they are generally also satisfied with surgery as the non-obese. And this is just an example for the discussion we had about socio-demographic and educations. We performed an analysis in our hospital on about 1,000 patients and looked about the risk of dissatisfaction. And you see patients who are living alone and have no husband or wife anymore because they are widowed. They have a 4 times higher risk of being dissatisfied than the patients who are in a stable personal relationship. School education, the more you are educated in school, the better is your satisfaction. So in other words, these factors all play a role, and you should have them in mind when you talk with your patients. And finally, we talked about depression. We also performed an investigation and looked patients preoperatively. The association of the optimism, different grades of optimism with the preoperative function in the WOMAC score. The WOMAC is another score like the Harris hip score. You see here the patients with a low optimism, medium and high optimism for the operation are pretty similar. 1 year after the operation, the patients who have a high optimism are significantly better than the patients with a low optimism. In other words, as you said, depressive patients tend to have worse results after surgery than optimistic patients. Again, the questions, which of these risk factors can you modify before the operation? Can you modify a preoperative clinical function? Of course, you cannot modify it really relevant, but you can pick up a patient early and not too late. Don't wait until the patient is lying and cannot walk anymore. Is it possible to modify the preoperative expectation? Yes, you can talk with the patient and sit down with him and tell him, well, you may have problems cutting your toenails. Don't expect to cut your toenails absolutely perfectly 6 months after the operation. I will talk about diabetes and obesity and show you 2 investigations. Who of you thinks that when you reduce overweight, then you will have a better result after surgery? Who thinks that? Okay. There's one investigation, very nice. 10,000 total knees, 4,000 total hips. The patients were investigated preoperatively and 1 year postoperatively. And preoperatively, all were counseled to lose weight. And when you talk to your patients, you must lose weight, you go into a program, into a diet and exercise program. It's pretty representative for all the series. About 80% could not change their weight preoperatively. About 18% really reduced the weight, and about 7% even increased it a little bit. This is pretty representative. And when you look 1 year postoperative, the surgical readmissions due to infection, there was no difference between these groups. Funny result, because we all would expect when you lower your weight, you would have less complications, but there is a lot of other investigations also. Obviously, a relevant reduction of obesity and of high patient weight before surgery is sometimes associated with problems, and it does not really reduce the complication rate. So it's frustrating, but the question is how to deal with a patient who is really overweight. What can you do with him after this intubation? Completely different is the question, how about to deal with diabetes? We all said diabetes is a risk factor. And this is a very nice investigation performed some years ago from an American group. They looked in patients who had a body mass index over 30 kilograms, hyperlipidemia, hypertension and diabetes, and they found out in those patients where these problems were not controlled, they had really a high rate of periprosthetic infections. In patients with a preoperative exercise program where you could control these risk factors, you had a 0% rate of periprosthetic infections, and when you compare it with a healthy control, it's absolutely the same. So in other words, to reduce infection rates, one really effective measure is to optimize diabetes together with hypertension and hyperlipidemia preoperatively. It's not just to reduce weight, it's just to optimize your physiology. Now we have talked about all these factors, and I come back now to the indications very briefly, because we now must transfer all these risk factors into indication program. What is possible to put these risk factors into indications? We have a huge number of international guidelines, but they are very diffuse, they are not very specific. These just always tell us patients who have pain and disability should be operated on. This is not very informative. We have really problems, and this might be one of the reasons why we have in several countries a very heterogeneous rate of arthroplasty. In the United States, you have regions with 6 times more arthroplasty rates than in other regions. In England and Germany, it's exactly the same. There's a large variation of arthroplasty rates, and one reason might be that we have no standardized indications. When you have a patient in your office and he comes and he asks you, when shall I have total hip replacement? We try now to get everything together. The patients normally start with very small problems, and over time the problems are increasing, sometimes more, sometimes less, sometimes more, sometimes less. And we now recall the investigation we had with worse improvement with very low function. I would say when you operate the patient very late in his course of the disease, you can improve him by a good degree, but you cannot bring him down to baseline. When you operate earlier, you improve him not as much, but you're coming closer to baseline. When you're operating the patient too early, you cannot be better than baseline. And what was the effect I told you before? What's the name of this effect? Ceiling effect, exactly. You cannot go below normal. Okay. So therefore, it would be the best to operate the patient in this situation in the optimal time for surgery. But when is optimal time for surgery? No one knows. And we have just to look over a few factors. There are a lot of algorithms in the meantime available who try to look and take all these factors together. I don't want to go in detail with these algorithms, but they do not function. This is one of the algorithms. You can put the patient pre-operatively and post-operatively, and you get cutoffs, but this is not really functioning. When you look in another score as well, it's always good bringing patients who are really suffering in a good situation, but you are never sure if a patient is suffering before the operation. You are never sure if you will get a good result or not a good result, so the specificity is not very good, and therefore you cannot at the moment recommend a real cutoff level in all these algorithms. You cannot say, like in a cookbook, I take together obesity and depression and preoperative function and say I make a score, and if the patient is at the score of 30, it's a good operation time. Many people have tried it, but they did not succeed. So in conclusion, I think it's always a personal decision between you and the patient to indicate total joint replacement. But you should be aware of all the risk factors in the back of your mind: obesity, diabetes, depression, employment, and. You should have a good impression of his real risk factors like cardiovascular situation and anything. And when you know his risk factors and when you know his problems, you can look for the optimal window. And when you have very high risk factors, you postpone the decision a little bit. When you have low risk factors, you do it somewhat earlier. But it's always, of course, a personal decision. So in conclusion, it's necessary to know the patient-related risk factors, and I hope I could give you some information about this. And it's important to know the results after total hip replacement, because when you bring these two things together, I think you can go into a very serious and honest discussion with the patient about this situation. That was what I wanted to tell you, and I'm open for questions if you have any questions. Thank you very much. Any questions?
You said that there is increased risk of periprosthetic fracture after 75 years. Are you